We're going to now move on to Jose. He has spent time both in North America as well as in Costa Rica, teaches widely like Anna and Irene and Renee. And I am looking forward to hearing your experiences, Jose.
Good night, everyone. I will be talking about internal medicine point of care ultrasound in Costa Rica. I am a fellow of American College of Physicians, and I'm actually chief of internal medicine department and coordinator of internal medicine residency program. I'm in charge of the point of care ultrasound little unit in our hospital. So I will share with you some of our insights. The objectives for this part of the presentation will be to demonstrate the extent of use of point of care ultrasound in internal medicine in Costa Rica, share some cases of general internal medicine wards where POCUS is daily used, and third, it will be to point some uses of point of care ultrasound in clinical areas outside the hospital. Okay, so let me tell you first a little bit about my country, Costa Rica. So this will be a general view of my country. Costa Rica is a small country. It's located in Central America, and we have a population of 5 million inhabitants. And the area of our country is about 51,000 square kilometers. Our health care is provided privately and public, but around 85% of our population use the public health system as the first option of medical care. And the public health system takes coverage around 90% of the population. So it's a good coverage. So you can say that the public health system takes care of almost all the country. So Costa Rica, it's a underdeveloped country, if you want to say in a way, but we have the same causes of mortality as a first world country. And actually, we have the first cause of mortality is circulatory system disease. Almost cardiovascular pathology could be assessed by POCUS. So I think that's quite important. And Costa Rica, we have like 8 schools of medicine. None of those actually use ultrasound or teach ultrasound as part of the med school. And we have only one residency program for all specialties in the public health system, actually. And we have more than 15,000 physicians and more of than 5,000 specialists. From them, around 500 are internists. And from this number, around 70% work at hospitals or clinics, and 25% works as primary care physicians. We are really proud that the last year, the point of care ultrasound was officially approved as internal medicine profile of by our College of Physicians. So now it's part of our profile. So we are now officially approved to do point of care ultrasound in different settings. We use point of care ultrasound, especially in rural areas, clinics, and hospitals. But I think the most frequent use is at the hospital. In hospital, we have ambulatory care units that actually use the point of care ultrasound. We have clinics, some of the clinics, especially thyroid clinic and neck clinic and other and rheumatology clinics use point of care ultrasound. Emergency room use a lot of point of care ultrasound, as internal medicine wards and ICU. We are trying to, or we are addressing point of care ultrasound as part of internal medicine residency program. So we are developing a program, a residency program that includes point of care ultrasound as part of the curriculum. And we are also doing a lot of training for staff, especially the new staff and some of our most experienced physicians that were not able to interact with this tool at some point. I will mention you frequent uses of point of care ultrasound in internal medicine. I think the most frequent uses here in Costa Rica, at least, will be the endocrinal ultrasound in those units, vascular access, especially in emergency room, neck and thyroid, like I told you. Lung ultrasound is really useful and really frequently used. Echocardiography is done as basic and advanced, depending on the expertise of the operator. We have also tests on abdominal ultrasound. Venous compression, looking for DVTs, is really frequently used. regional anesthesia, especially by pain clinics and by anesthesiologists. We also do a lot of procedures. Last year, before, I think like 2 years before, almost all procedures were done blindly in Costa Rica. But since the last 2 or 3 years, all these procedures are done guided by ultrasound. We do a lot of protocols, especially fast, blue, rush, and falls. And we have a lot of difficulties spreading the tools. And I think the most important ones are that we have little to none exposure at med school to point of care ultrasound, so we don't are used to interact with the machine. We have limited access to hands-on training, formal courses. We also have some difficulties in accessibility to the equipment, especially in clinics and hospitals where the budget is limited. And we also are facing oppositions from different branches. I think especially from different branches, especially radiology and cardiology. But I think it was especially at the beginning. Now, the past couple of years, we're feeling that there's more support from these specialties. And there is a perception, especially from the more experienced staff, as a time-consuming tool. But when the staff is exposed, usually they agree that it's really useful and could be a quick way of assessing patients. I will share with you some of our cases so you have an idea how we are using ultrasound here in Costa Rica. So this is a case of a 60-year-old female patient with history of exposure to firewood smoke since childhood, hypertension, diabetes, obesity, hypercholesteremia, osteoporosis, and COPD. So this is quite common in our country. And she came here to our hospital, arriving with a history of recent dyspnea and with medium efforts, and now with small efforts, with productive cough, with a scan expectoration and constitutional symptoms. At a physical examination, we found tachycardia and tachypnea, afebrile, and with pulmonary exploration with a relevant findings. We found a cardiac murmur that could be compatible with mitral regurg or tricuspid regurg. And the chest X-ray, as usual, here you can see the chest X-ray with a poor technical quality. That's really common in our hospital. So we use the ultrasound. We assess ultrasound as part of. We find B lines. I'm having a slow picture here, but we find also fluid at her right basis, and we find B lines here at the apex of the left lung, as same as right lung, and we also find fluid at the basis of the left lung. We assess the focused assessment of the echocardiography in this patient, and we found a systolic dysfunction, moderately one, and dilatation of the left ventricular chamber. And the IVC, as you can see here, was like enlarged and without a compression with or decreasing of diameter with inspiration. So we made the diagnosis of a heart failure, and we treat this patient that was in a way misleading us to different diagnoses. We treated in the right direction right away at the emergency department. And this other case is also a common case. It would be a 72-year-old male patient with a history of smoking, around 50 packs a year, and hypertension, diabetes, COPD, RISC-T, with a recent hospitalization and obesity. He was bring out with a dyspnea of medium efforts, progressing until present at rest, hitting eyes, orthopnea or nocturnal paroxysmal dyspnea, and the physical examination with normal blood pressure with increased heart rate. And we found like jugular ingurgitation at 48 degrees with no hepatojugular refluxes, but with arrhythmic hypophonetic heart sounds and a leg edema at the left leg. So we were assessing this patient, and we were asking if this patient has COPD exacerbation, or could be heart failure, or could be also the thing that we were looking for. It was for embolism. We found that this with this echocardiographic approximation, we found that there was a design with an enlargement of the right ventricle, as you can see here, almost the same diameter of the left ventricle. And we assessed also the left leg, and we found a clot, one that wasn't compressible at the femoral vein, the common femoral vein. So we did the diagnosis of a deep vein thrombosis and a possible embolism with hemodynamic repercussions. And we asked for a CT, and actually the CT showed the pulmonary embolism. So the patient was treated in less than 2 hours, and helped us to manage in the right direction the patient. And the last case I bring to you is a 60-year-old male patient with a history of smoking, around 30 pack year, hypertension, diabetes, and with a history of poor control of both disease, with AFib, without any anticoagulants prescribed before, and a heart failure, NIH class 2, with an end-stage renal disease, stage 3A. The patient has also a history of peripheral artery disease with an amputation, and was brought with history of sudden motor deficit, with a right upper extremity weakness and dysarthria. So at the physical exam, we found also dysarthria and the problems moving his right hand. So we were probably between it was a new stroke, but we were dealing with, we were not sure if the stroke came from actually the AFib or something else. We heard a murmur, so we take a look at the murmur, and you can see here a really enlarged left ventricle. And the murmur actually was because the patient was having a mitral rigor, but you can see that there's something at the apex there. So we changed to a short axis view, and you can see there a clot, a big clot. And with the 4-chamber view, you can see that the clot is actually huge. And the reason of the stroke was this clot, and probably not the AFib. And we managed this patient more aggressively, and we asked to consult to other specialties to manage this patient together. So I think also it's important to see that this patient was not with a heart failure, even with a really low or severe systolic function. The patient actually was not in a heart failure or decompensated heart failure. So I think with these cases, I can show you some common cases that we can address actually in the internal medicine wards or in the emergency room, and the patients will be beneficiated from this tool. I will talk with you just a couple of more slides about some of the uses of point ultrasound outside the hospital here in Costa Rica. We use it for ambulatory care, especially at pain clinics or palliative care clinics, where the ultrasound is used in the home of the patient. Point of care ultrasound has been used also as private office practice, and actually that's something that it's increasing in the last couple of years, since the ultrasound the prices are getting lower. We also use the ultrasound, and this is something that I love, is that we could use this equipment as a portable equipment, so you can get the equipment to really difficult areas or areas of difficult access. You can see here a family physician, a good friend, that is taking care of a patient at her home, actually, and you can carry the ultrasound through a river and get to her home to take care of the patient. And I also love that you can use the ultrasound in different areas. So where you only can access, for example, by chopper. This is an indigenous reserve community that actually can be only accessed by chopper. and it's really far away from the big cities here in Costa Rica. So you can take care of the ultrasound, and actually the ultrasound is usually a good tool and is often used there at the indigenous communities. So that will be my insight from Costa Rica for point of care ultrasound. Thank you, and I hope that you enjoyed the part. And if you have any question at the final of the next slides and the webinar, we can talk. And the next slides will be for Irene, and she will talk a little bit more about the point of care ultrasound uses. Thank you.
Thank you very much, Jose. That was a great presentation. I love all the ultrasound video, but do have to apologize to everyone. One of the hallmarks of point of care ultrasound education is the use of real-time video to tell the story, to educate, but obviously that's bandwidth heavy, so sometimes that can result in choppy images or slow moving images. So my apologies for that.